Bridget, thank you. Hello, everyone. Welcome to new clinical developments in the treatment of acute migraine with remote electrical neuromodulation. My name is Dave Duff. I'm the head of marketing for Theranica USA, who's the sponsor of tonight's program, and I'll be your moderator tonight. At this time, all participants are in listen-only mode. You may ask a question anytime by entering it into the Q&A box located on the upper right side of your screen. We'll get to the questions during the question and answer portion of the presentation, and we'll try to answer as many of the questions as time permits. The audio for tonight's presentation is streamed over the internet. If you're having any audio issues, please dial the phone number and passcode listed in the chat box, which should be in the middle of your screen. So let me introduce tonight's esteemed faculty. We're glad you're here to listen to them. Our first speaker this evening will be Dr. Steven Silberstein. Dr. Silberstein is a professor of neurology and the director of the Jefferson Headache Center at Thomas Jefferson University. He has published widely and has been an active researcher in headache for many years. We're also pleased to have Dr. Brian Grosberg with us tonight. Dr. Grosberg is the director of the Hartford Healthcare Headache Center in Connecticut and is professor of neurology at the University of Connecticut School of Medicine. He has also published widely and has been a researcher in headache for a number of years as well. Okay, and then let me just touch on the indication and important safety information for Nerivio real quick, and then we'll review the agenda and turn it over to Dr. Silberstein. So Nerivio is indicated for acute treatment of migraine with or without aura in patients 18 years of age or older. It is a prescription use, self-administered device for use in a home environment at the onset of migraine headache or aura. Nerivio should not be used by people with congestive heart failure, severe cardiac or cerebrovascular disease, or uncontrolled epilepsy. Nerivio should not be used by anyone with active implantable medical devices such as a pacemaker or hearing aid implant. It should only be applied on the upper arm over dry, healthy skin with normal physical sensation and without any metallic implants or in proximity to cancerous lesions. Nerivio has not been evaluated in pregnancy or those under the age of 18. For full use instructions and safety information, please see the Nerivio user manual available at nerivio.com. With that, let's take a quick look at tonight's agenda and we'll get started. So first, Dr. Silberstein will start us off with a disease state review and then talk about the mechanism of action of Nerivio. And then he'll turn it over to Dr. Grosberg, who will review the clinical data, including the important new clinical information that we have to share with you tonight. And then he'll turn it back to Dr. Silberstein to talk about some of the clinical practice implications, and we'll wrap up with that question and answer segment. All right, with that, let me turn it over to Dr. Silberstein. The floor is yours.
Thank you. I'm going to start by talking about the migraine disease state and looking for my, could you just advance the slide? I don't know what happened to my bar.
Okay. There we go.
I'll just say, migraine affects about 14% of the population in the world. It's estimated by the World Health Organization that's the second most disabling condition. In the United States, more than 40 million people have migraine. Peak prevalence occurs during the age of greatest social, economic productivity, and child rearing. Migraine is associated with increased use of healthcare resources. It's one of the top 20 reasons for medical visits and the top 5 reasons for emergency department visits. Next. Well, how do you diagnose migraine? It's International Headache Society criteria, but basically it's 3 parts. 1, the duration of the attack. Why it's 4 hours? Who knows? Why 72 hours? Who knows? 2, it requires 2 of 4 headache characteristics, including one-sidedness, pulsating, moderate severe pain intensity, and aggravated by physical activity. So if you have a one-sided moderate headache, it doesn't have to be pulsating, it doesn't have to be aggravated by physical activity, as long as you have nausea and or vomiting, or both photo and phonophobia. But really, to make it simple, if a patient complains of a disabling headache that comes and goes, more likely than not, it's migraine. Next, please. What are the migraine triggers? It is believed that certain things can bring on a migraine attack. Some are real, probably, or some are mythological. It's quite clear that alcohol, missed meals, not getting enough sleep, let down from stress and menstruation can trigger migraine. But there's really no good evidence that chocolate can trigger migraine. And I'll never forget a meeting once where we found out that in England, red wine gives you headaches. In France, it's white wine, but I think it's bad wine that gives you headaches, not the wine itself. Next slide, please. So let's next talk about the mechanism of action of the Nerivio device. It's called remote electrical neuromodulation. And what it does, and I'll talk about this in greater detail in a few minutes, it triggers the endogenous descending pain control system. It's called in humans conditioned pain modulation. It can be used alone or in combination. It's typical for usual treatment. The individual dosage and intensity is set by the user. And it's a disposable device where you get 12 45-minute treatments. Next, please. What are we talking about? What is conditioned pain modulation? It's the body's endogenous analgesic mechanism occurring when a painful stimulus is hit by a second painful stimulus elsewhere in the body. So, it's mediated by the brainstem, descending pain inhibition mechanism. The stimulus must activate pain or nociceptive fibers, but can be below the perceived pain threshold. Stimulus must be remote from the pain location, and the global effect can last beyond the time of stimulation. In contrast, what is TENS? It's based on the gate control theory of Melzack and Wall. It's tactile stimulation in the same dermatome as the pain, and it's a local effect only in the areas of stimulation. Next, please. So, this is the model. We have migraine headache signal going up through the trigeminal cervical complex mediated by the A delta and C fibers. In contrast to being at the local level, Wren stimulation involves C and A delta fibers and goes up into the brainstem. Next, please. Eventually, through connections in the periapical day and the locus ceruleus. Next, please. There's a descending inhibition system, which then goes back and turns off the signal coming in. So basically, the difference is with conditioned pain modulation, it's a general anti-nociceptive system. Next, please. So let's compare TENS versus Wren. Conditioned pain modulation is descending pain inhibition, whereas Wren is really inhibition of the pain before it ascends. In conditioned pain modulation, involving the C and A delta fibers. In TENS, it's the A beta fibers, which are the fibers which are not for pain. In conditioned pain modulation, the nociceptive fibers are stimulated. In TENS, it's touch. In conditioned pain modulation, it's remote from the pain location, but transcutaneous electrical stimulation with the gate theory as the same localization of the pain. There's a higher pulse frequency with conditioned pain modulation, and the pulse width is slightly longer. And remember, the impact for CPN is global. In contrast, the gate theory is local. Next, please. So, to reiterate, the mechanism of Wren is distinct from the gate theory. It's the activation of a brainstem-mediated descending pain inhibition mechanism. The stimulus must activate nociceptive fibers, but it typically can be used below the perceived pain threshold. The stimulus must be remote from the original pain location, and the global effect lasts longer than stimulation. If you've never heard about it, you've practically done it. You ever stub your toe and then squeeze and massage your leg? That's conditioned pain modulation at work. Next slide, please. My partner for the evening, Brian Grosberg, will now be talking about the pivotal clinical data.
Thank you very much. So I'm going to speak to you today and tonight about the clinical data, starting with the pivotal trial. This was, I'm going to advance the slide here, this was a prospective, randomized, double-blind, sham-controlled, multi-center study that was conducted at 12 sites, 7 sites in the United States and 5 sites in Israel. There were 252 adults that comprised the intent-to-treat population who met the International Classification of Headache Disorders criteria for migraine. These patients experienced 2 to 8 migraine headaches per month and were randomized in a 1-to-1 fashion to either active or sham stimulation. And of the 252 participants, 202 comprised the final analysis set that completed the test treatment. And to be included in the study, patients were between the ages of 18 to 75. They met the International Classification of Headache Disorders criteria, experienced 2 to 8 migraine headaches per month, but no more than 12 headache days per month. And they were either on no preventive medications or they were on a stable dose of a preventive medication in the 2 months prior to recruitment. The exclusionary criteria were those who were pregnant, nursing, or trying to conceive, those patients who had pure menstrual migraine, those who had an implanted electrical device, or patients who had received intravenous medications for headache or onabotulinum toxin or nerve blocks in the weeks to months before the study. And I'm going to go through it in a little bit more detail, but there were 3 phases. Essentially, there was a 4-week run-in phase before the randomization, a 6-week double-blind treatment phase, and then an 8-week open-label phase. And the results of the study were published in the journal Headache in May of 2019, I believe. The primary endpoint was 2-hour pain relief in the primary attack on a 0 to 3-point scale, and the secondary endpoints at 2 hours post-treatment in the primary attack were most bothersome symptom relief, pain and most bothersome symptom relief, pain freedom, and most bothersome symptom freedom. And so I'm going to break down the study design for you here. Looking at the left, after enrollment, study subjects were first trained to use the electronic diary app installed on their smartphone. Participants then completed the migraine diary for 1 month during the, quote, run-in phase, in which all the migraine attacks were documented, noting baseline pain and 2-hour post-treatment pain, rating it on a 0 to 3-point scale. And during the run-in phase, participants treat their attacks of migraine with usual care, which could include migraine-specific and non-specific medications. And after this, eligible participants were then randomized in a 1-to-1 fashion to either active or sham stimulation in a double-blind manner. At this point, participants were then trained to use the device for the acute treatment of migraine, and this really included finding their own optimal individual stimulation intensity level that was well felt but non-painful as per the description that Dr. Silberstein just gave. And the training was specifically done on the device assigned to the individual patient. This really was done to maintain the blind. During the 6-week double-blind treatment phase, study subjects treated their migraine attacks at onset and always within 1 hour of symptom onset with the device, starting with their own optimal stimulation intensity level. And what you'll see here is the first attack training. And the first reported treatment was considered a training treatment, which verified that the participants who used the device, that they used it properly, and it was only included in the safety analysis. More than 90% of the participants used the device correctly. And then finally, the next attack, which was, quote, considered the primary attack, was the first fully treated attack following the training attack. And this was the migraine attack that was used for the efficacy and safety analysis. This attack was treated within 1 hour of symptom onset, and study subjects were then allowed to treat up to 3 additional attacks, and then had the opportunity to be enrolled into an 8-week open-label treatment phase using the active treatment. So looking at efficacy at 2 hours post-treatment, if we look on the left here for the primary endpoint of pain relief at 2 hours post-treatment, 2/3 of participants in the active group achieved pain relief for the primary attack compared to nearly 39% in the sham group, accounting for a therapeutic gain of 28%. For the secondary endpoint of pain freedom at 2 hours post-treatment, 37.4% of the participants in the active group were pain-free compared with 18.4% in the sham group. Looking at the graph on the right for 48 hours sustained pain response, the outcome of sustained pain relief at 48 hours was achieved in 39.1% of participants in the active arm versus 16.9% in the sham treatment group. And the outcome of sustained pain freedom at 48 hours was achieved in 20.7% of participants in the active arm versus 7.9% in the sham treatment arm. In terms of device-related adverse events, looking at safety analysis, they were performed in all 252 participants that were included in the intent-to-treat population. As you can see here, there were 23 device-related adverse events that were reported during 773 treatments. This was accounting for 2.7%, 14 in the active group, 9 in the sham group. The incidence of device-related adverse events was low. I believe it was less than 4%. Similar between the treatment groups, the device-related adverse events that you notice here, muscle spasm, tingling, neck pain, arm pain, itching, a sensation of warmth, redness, and numbness. All the device-related adverse events were mild in severity, resolved within 24 hours, and didn't require any medical treatment. There were no systemic side effects. There were no serious device-related adverse events, and no discontinuations due to adverse events. So I'm now going to pivot, and we're going to shift our attention from the double-blind phase of the pivotal trial, once again for acute treatment of episodic migraine, to two separate studies of acute treatment of migraine in patients with chronic migraine. And what's notable is that these two studies are really some of the first studies performed establishing guidelines for treatment of migraine acutely in patients impacted by chronic migraine. So this is new data. A number of years ago, one of my mentors, Richard Lipton, described migraine really as a chronic disorder with episodic manifestations, episodic attacks, with two major subtypes differentiated based on attack frequency. Episodic migraine, characterized by attacks that occur fewer than 15 days per month, whereas patients with chronic migraine have headaches on at least 15 days per month, of which at least 8 of those days either meet criteria for migraine or respond to migraine-specific treatment. Chronic migraine is perceived as a disabling complication of migraine with a population prevalence of about 1 to 2%. And typically, chronic migraine will develop after a progressive increase in headache frequency over months to years in a process that can be conceptualized as chronification. Annually, about 2.5 to 3% of people with episodic migraine will then go on to progress to chronic migraine. And risk factors for migraine chronification consist of non-modifiable risk factors, which can include older age, female sex, low education level, a poor socioeconomic status, genetic factors, and then modifiable ones, some of which include medication overuse with particular culprits for certain types of medications, a high attack frequency, obesity, snoring, stressful life events, and mood disorders, to name a few. And although the exact mechanism that underlies this association is not clear, we believe that less effective acute treatment of migraine can lead to a more frequent intake of acute medication or increasing dosages, which in turn could lead to headache progression. And thinking about that in mind, there is always a constant need for new effective acute treatments that will reduce the risk for migraine chronification. And so what I'm going to show you is really the first pilot study for acute treatment using remote electrical neuromodulation in chronic migraine. So this was a prospective, open-label, single-arm, dual-centered study conducted at one site in the United States and one site in Israel. Patients were eligible to participate if they were between the ages of 18 to 75 who met international classification of headache disorders criteria for chronic migraine and were either on no preventers or a stable dose of a migraine preventive medication in the 2 months prior to recruitment. Once again, chronic migraine where patients are experiencing at least 15 days of headache per month of which at least 8 of those days either meet criteria for migraine or respond to migraine-specific treatment. Some of the exclusionary highlights were those patients who were pregnant or breastfeeding or trying to conceive, those patients who had an implanted electrical device or congestive heart failure or severe cardiac or cerebrovascular disease, uncontrolled epilepsy, or a previous experience with the device. And participants treated the migraine headaches for 45 minutes within 1 hour of attack onset. What I want to just end up emphasizing that is that the participants in the study treated all the headaches, but only the qualifying headaches, which I'm going to define, were included in the intent to treat analysis. And so what they defined as a, quote, qualifying headache was either someone who had a moderate or severe headache that was preceded by 24 hours of no pain or mild pain, or someone who had a mild headache that was preceded by 24 hours of no pain. And then pain was reported on the 0 to 3-point scale, where it was either none, mild, moderate, or severe. And the primary endpoint was 2-hour pain relief, with secondary endpoints of 2-hour pain freedom and 2-hour associated symptoms. And the exploratory endpoints were within subject consistency of pain relief, which is looking at the percentage achieving pain relief at 2 hours in at least 50% of all treatments, and functional disability at 2 hours post-treatment, which is looking at the proportion achieving improvement of at least 1 grade in functional disability. And then this was a 4-week treatment up to 4 attacks. And so next slide. So looking at the results, once again, just for context, the study was conducted from September 2019 to February 2020, so right before the, so to speak, peak of COVID, if you will. 42 patients were enrolled and received a device. They comprised the intent to treat population. 38 of the participants had valuable data. 2 withdrew. One said the protocol requirements were too time-consuming for them, and another due to treatment intolerability. There were 2 others that did not have a valuable treatment, so that was not reported. The demographic and clinical characteristics of the participants and the characteristics of the treated migraine headaches were comparable to those reported in other studies of migraine. Just some information about the pain severity of the treated migraine headaches. Most of them were moderate, a little bit more than half, and nearly 20%, a little less than 20% were severe. There was a total of 210 evaluable treatments from 38 participants, with an average of 5.5 qualifying treatments per participant in the 4 weeks. And the average number of headache days per month was a little over 21, with an average number of about 18 migraine days per month. 64.3% were on a stable dose of a preventive medication. There was roughly 90% compliance with avoiding medication at 2 hours. In terms of safety, there was 1 device-related adverse event, which included bilateral tingling of the temples, and disturbance, and double vision, and it was moderate and resolved within 48 hours following treatment with a triptan. Looking at pain responses at 2 hours, so if I'm looking here on the left, at 2 hours, the mean pain relief rate across subjects was 50%. 26.3% of the participants experienced pain freedom in at least 50% of their treated attacks. If we look on the right in terms of consistency pain relief in more than 50% of all the treatments, the consistency analysis across all the attacks demonstrated that 73.7% of participants experienced pain relief in at least 50% of their treated attacks. So that was the pivotal study for acute treatment in chronic migraine. This is the 2nd study that was done, a much larger study. So the current study assessed the efficacy and safety of remote electrical neuromodulation in people with chronic migraine. This was an open-label, single-arm study in people with chronic migraine. Once again, a 4-week treatment phase in which subjects were asked to treat their headaches with the device. Pain levels, associated symptoms, and functional disability were recorded. At treatment initiation, 2 hours and 24 hours post-treatment. This study, as opposed to the other one, which was at 2 sites, this was conducted at 9 sites in the United States. Patients, once again, were between men and women between the ages of 18 to 75 who met ICHD-3 or International Classification of Headache Disorders criteria for chronic migraine, experiencing at least 15 headache days per month, with at least 8 of those days meeting criteria for migraine or responding to a migraine-specific treatment, either on no preventives or a stable dose of a migraine preventive in the 2 months leading up to recruitment. And subjects were allowed to have up to 23 headache days per month. Once again, a qualifying headache because these guidelines really are kind of novel for acute treatment in patients who are impacted by chronic migraine. Qualifying headache defined as having either a moderate or severe headache preceded by 24 hours of no pain or mild pain, or experiencing a mild headache preceded by 24 hours of no pain, with pain reported on a 0 to 3-point scale with either none, mild, moderate, or severe. The efficacy outcomes included the proportion of subjects who achieved pain relief at 2 hours post-treatment, which was defined as improvement from severe or moderate pain to mild or none, or improvement from mild pain to none. The proportion of subjects who achieved pain freedom, right? This is improvement from mild, moderate, or severe pain to no pain at 2 hours. The disappearance of associated symptoms, which could include nausea, vomiting, photophobia, and phonophobia at 2 hours. Sustained pain relief at 24 hours, sustained pain freedom at 24 hours, and improvement in functional ability at 2 hours, which again would be defined as a reduction of at least 1 grade. The exploratory endpoints also looked at within subject consistency of pain relief, which was defined as the proportion of subjects achieving pain relief at 2 hours in at least 50% of their treated headaches. And so this study, once again, I'm going to just walk you through. This was conducted from November 2019 to May of 2020. So that was the end of the treatment phase. There were 126 participants that were enrolled, of which 7 subjects withdrew consent during the run-in phase. And this was for any number of reasons, which could include that they didn't want to travel to the site, or they were unable to comply with protocol requirements, or they didn't want to come into the clinic due to the COVID pandemic and a remote visit wasn't possible. And then there were several patients that didn't specify the reason. 1 subject was lost to follow-up during the run-in phase, and 19 completed the run-in phase, but were not eligible to continue according to protocol specifications, which required the subject to treat a minimum and report a minimum number of attacks with pain data at the baseline in 2 hours during the run-in phase. And so walking you through, accordingly, 99 subjects entered the treatment phase and received the device. 8 subjects were withdrawn because they had no evaluable test treatment. And finally, the final analysis that was comprised of 91 subjects. The demographics and clinical characteristics of the 126 subjects that enrolled into the study consisted, once again, of published reports on patients with chronic migraine, mainly middle-aged Caucasian women. The clinical characteristics of the subjects also correspond with a chronic migraine diagnosis according to the International Classification of Headache Disorders criteria. There, as you can see here, there was 1 device-related adverse event of pain in the arm felt following use of the device on that specific arm, which was mild and resolved within 24 hours without medication. There were no serious device-related adverse events, and none of the subjects withdrew from any of the study due to device-related adverse events. And so, once again, if we look at pain response at 2 hours, during the treatment phase, there were a total of over 700 qualifying migraine headaches that were treated with remote electrical neuromodulation. There were an average of a little over 7 treatments per participant over the 4 weeks for the 97 participants. And there was baseline pain level data for over 600 treatments. Just to give some context, the pain severity of the treated migraine headaches was mostly moderate, about 57%, and nearly a quarter of the subjects treated for the migraine headaches for a quarter were severe for 25%. Looking at pain relief and pain freedom at 2 hours, on the graph on the left here, that was achieved by 59.3% and 20.9% of the subjects respectively. Pain relief was sustained for 24 hours and nearly 3/4 of the subjects. Looking at most bothersome symptoms, so nausea, photophobia, and phonophobia, disappeared at 2 hours, anywhere from 40% up to nearly 50% respectively, of the participants. Furthermore, almost 60% of the subjects experienced improvements in functional ability at 2 hours. Looking at the graph here on the right, in terms of consistency for pain relief in at least 50% of all treatments, the consistency analysis demonstrated that 57.1% of the subjects experienced pain relief in at least 50% of their treated attacks. Now I'm going to turn the rest of the presentation over to my colleague, Dr. Silberstein.
Thank you. Next slide, please. One of the interesting things about this Serenigod Nerivio device is the association of the app for your cell phone. It now applies digital health. Next slide, please. So what are the things it can do? It can track the number of headaches you have. It can track the intensity, the associated features, and there's something new we shall talk about in a moment. Healthcare physicians recognize the value of using electronic migraine diary to improve migraine management. The Nerivio device empowers patients to track their migraine patterns and outcomes and share this information with their healthcare providers. The Nerivio device facilitates optimal treatment outcomes by providing patient-level data to treating healthcare providers and the healthcare team. Important to realize all the data is stored on a HIPAA-compliant server. The app provides individual tips to improve adherence and maximize the clinical benefits. The app provides guided imagery, education, and relaxation. It's a new feature, so in addition to the device itself, they have the opportunity for other non-pharmacologic treatment. Next slide, please. So what are some practical tips for the best results? Start as soon as possible, within 60 minutes of the onset of the headache pain. If you're not sure you're getting a headache and you feel you might be getting one and it's just beginning, you can put the device on. As long as you don't start it, you haven't used it, and you still haven't lost one of your treatment sessions. Wait, go back, please. Hello? So, you position Nerivio in the upper arm, midway between the shoulder and the elbow. You gradually increase the stimulus intensity to feel strong but not painful, and try to get a better level of 20. After the 45-minute session is completed, the device will turn itself off automatically. Tell patients how it works. Nerivio works by activating the natural pain inhibition pathway in the brain that can stop migraine headache pain. And, you can tell your patients when they go to the dentist and they're mouth drilling, if they just squeeze their finger real hard, that'll take the pain away. That's conditioned pain modulation. There's instructional videos and Nerivio Care's customer support to assist patients to safely and effectively use Nerivio. Nerivio can be used in conjunction with other usual treatments consistent with the product label. And there are really no limitations on how often the patients can use Nerivio. Next, please. In summary, this is an FDA-approved, authorized, de novo Class 2 medical device indicated for the acute treatment of migraine. What is Class 2? Class 1 are Band-Aids. Class 2 are like electric wheelchairs. That means minimal risk. Wren triggers the endogenous descending pain-modulated mechanism, conditioned pain modulation. The clinical data shows consistent high efficacy in both episodic and chronic migraine. It's a safe alternative to migraine medications with comparable efficacy to the best pharmacologic treatments, but providing a more favorable side effect profile. It may provide benefit. Patients have not responded to prior treatments, did not tolerate them, prefer a drug-free treatment, or at risk for medication overuse. Next, please. It's the first in the class digital therapeutic for acute migraine treatment, which utilizes a unique mobile app, and it provides digital support, therapeutic support, real-time clinical decision-making during telehealth or in-person clinical visits. Nerivio's safety profile, proven efficacy, and affordability enables healthcare providers to add neuromodulation to the migraine patient's toolbox. Next, please. And I'm going to turn this back over.
Dr. Silberstein, Dr. Grosberg, thank you both so much for lending your expertise to tonight's program. So what I'm going to do now is just touch on prescribing Nerivio. And one of the most common questions that we get asked at Theranica is the device covered by insurance. And so, Theranica, as many people are aware, there's 3 other devices cleared by the FDA for migraine. None of those devices are typically covered by insurance, but at Theranica we've really been trying to be focused on making sure that Nerivio is available and affordable to as many people with migraine as possible. So we've established the Nerivio Express Savings Program so that any patient with valid and active medical insurance can get their first prescription for no more than $10. And this includes government-insured patients. And then refills, can be as low as 0, but not more than 99. It depends upon the specifics of their insurance policy and the coverage that their insurer provides. But this at least allows patients to get a low-cost trial of Nerivio with the opportunity to have their refills at a low cost as well. Now, Theranica is not pursuing government insurance coverage at this time, so government-insured patients will end up paying the maximum of $99 for their refills. But, at least, those, if they're Medicare patients, they'll never find themselves in the donut hole paying full price for therapy as they do sometimes with medications when they hit that donut hole. So what you see on the screen on the right-hand side is the enrollment form. It's a one-page form that needs to be filled out and sent to ProCare Pharmacy, is who we have partnered with to do the benefits investigations for people. So the form is just filled out by the healthcare provider and faxed or emailed to ProCare. You can also use electronic medical records or EMR as well. The only clinical information required is the ICD-10 code, which there is a space for on the form. And finally, since Nerivio is often reimbursed as a durable medical equipment, it's rare that it will impact the managed care access to medications that a person might already be taking. And so, all of this we think, makes Nerivio an excellent addition to the patient's migraine toolbox, as Dr. Silberstein said.